All right, so just a quick ground rule. If you could please save your questions until the end of the presentation, as I want to make sure and get through all of the topics first, but I really appreciate your time and looking forward to all of your questions. So let's go ahead and get started. So these are the topics that we're going to cover during this presentation and also on the following slides. So as you can see here, we're going to talk about the prevalence of COVID-19, how COVID-19 was identified, COVID-19 structures and their relevance for infectivity, risk for COVID-19 based on comorbidities, age, and race, epidemiological and clinical criteria used to diagnose COVID-19, COVID-19 signs and symptoms in the general population, and the elderly in comparison to influenza. We're also going to talk about testing options for COVID-19, isolation and quarantine, and the importance of telemedicine, case examples of quarantine scenarios. I'm going to give you a Portage County update and the status of our hospitals in the region. All right, so as the saying goes, grab your reader's attention, and nothing grabs our attention greater than seeing these graphs and pictures of the staggering numbers of COVID-19 cases in the world and the United States. This graph shows the number of cases in the world each week from December 31st, 2019 to November 10th, 2020. And it goes from 0 to 700,000 people. So remember, this is every week of COVID-19 cases throughout the world. The take-home point here is not only the total number of cases, but as you can see, the exponentially increasing numbers that are very far from leveling off. This slide shows the number of COVID-19 cases in the United States for just 1 week from October 28th to November 3rd, 2020. The darker the color, the higher the number of cases, with Ohio being in the second darkest color, which represents between 14,000 to 24,000 cases, again, just for 1 week. This is a picture of all 88 counties in Ohio showing the increasing number of COVID-19 cases based on the 7 indicators of the Ohio Public Health Advisory System, which we'll discuss later. In 1 month, from October 1st to November 5th, 2020, the number of counties at level 3, which is red of 4 levels, went from about 16 counties to 68 counties. This is the most sobering graph, and it shows the total number of confirmed COVID-19 deaths in the world. North America is represented by the green color, which is very close to the highest number of cases. As you can see, the number of deaths have increased exponentially without a current end in sight. All right, so let's switch from talking about the prevalence of COVID-19 to one of the ways that COVID-19 was positively identified. Here's a picture of the SARS-CoV-2 virus, also known as COVID-19. The red triangular areas that are protruding from the surface are the spike proteins, which form a sort of crown around the virus, which we will be discussing in the next couple of slides. So how do we know for sure what the virus is and where it fits into our classification of organisms? Well, based on phylogenetic analysis, which shows the evolutionary relationships between biological species based on the similarities and differences in their genetic and their physical characteristics, and also by what's called homology modeling, which compares species based on their amino acid sequences, we know that the SARS-CoV-2 virus is very similar to SARS-CoV-1 and MERS, which is the Middle Eastern Respiratory Syndrome virus. Based on this information, the SARS-CoV-2 virus has been identified as a member of the coronavirus family, and it's from the Beta genre. The top of the slide shows the phylogenetic analysis, and over here where we have the red asterisk is our virus. And then the bottom of the slide shows the homology modeling. And you'll see, we'll talk about this in a second, but this is the SARS-CoV-2, which is earlier identified as 2019 nCoV or CoV. So knowing the classification of the virus is important, as it helps us understand the characteristics of the virus, such as the mode of transmission, which is mainly respiratory, just like SARS-CoV-1 and MERS. Just so you know where the word COVID-19 came from, on February 11th, 2020, the World Health Organization announced an official name for the disease called the 2000 novel, which means new, coronavirus outbreak, which was first identified in Wuhan, China. The new name of the disease is coronavirus 2019. Again, it's abbreviated as COVID-19 because the CO in COV and the COVID stands for corona, the VI stands for virus, and the D is for disease. Formerly, this disease was also referred to as 2000N CoV, which again, you can see right over here. So now that we have positively identified COVID-19, let's discuss the structures as they are relevant in understanding the infectivity of the virus. So remember those red spikes I showed you that surrounded the virus like a crown? You can see them identified on the very top of the left-hand side of this slide right here. It says spike, which is a representation of what the coronavirus would look like if you sliced this completely in half from top to bottom. On the right part of the slide is a drawing of the spike protein in detail. On the left-hand side, you can see the S1 and S2 subunits and the RBD, which is the receptor binding domain. And because we're going to discuss this later, I want to point out this nucleocapsid protein N, which is right over here. That's part of the DNA of the gene. All right, so before moving on to a further discussion regarding the spike protein, if you remember, there was an original SARS pandemic from the SARS-CoV-1 virus back in 2003 in 26 countries. Surprisingly, it only resulted in about 8,000 cases, which is nothing compared now to over 10 million in the United States and over 50 million in worldwide and growing. So why was the original SARS-CoV-1 virus infectivity so very low compared to the SARS-CoV-2? Well, one theory has to do with this low receptor binding in the SARS-CoV-2 causing some immune evasion going on, and hence the increased rates of infection and transmission. So now we're going to talk about risks for severe COVID-19 infection based on comorbidities, which are medical conditions that are already present in the body. Research has demonstrated that one of the main pathways that SARS-CoV-2 enters the cell is through the spike protein binding to the ACE2 receptor. You'll see a picture of that right here. And the ACE2 stands for angiotensin converting enzyme 2, which is one of the main pathways in blood pressure control. As you may be aware, people can be put on what are called ACE inhibitors for hypertension or high blood pressure, and that works on the same pathway. It has been theorized that the reason that those with hypertension are at increased risk for severe COVID-19 is due to this pathway of cell entry by the virus. The risk translates to other associated conditions which affect the virus of the heart, such as diabetes, high cholesterol, kidney disease, heart electrical pathway problems like atrial fibrillation, and heart failure. So here's a slide back on April 6, 2020, about leading comorbidities among COVID-19 deaths in New York. And it's a very dramatic graph. So even though it's a little bit of an older date, I went ahead and kept it in here for this information, which shows that the leading comorbidities, which again are the medical conditions that we have currently in our body, show that hypertension was by far the leading comorbidity among those who died from COVID-19. COVID-19 is primarily transmitted through respiratory droplets, again, just like SARS-CoV-1 and MERS. So those with underlying lung diseases such as chronic obstructive pulmonary disease or COPD are at increased risk for more COVID-19 symptoms, including needing hospitalization, ventilator support, and even death. Well, it's no surprise to anyone that as we get older, we have increased risk of having underlying medical conditions, meaning comorbidities. Those underlying conditions may require hospitalization, ICU admission, and ventilator support. So this graph shows a number of hospitalizations per 100,000 people based on age, from 0 to 4 years to 85 years of age, with the highest number of hospitalizations being from the 80 in the oldest age category. Like a lot of diseases, they tend to affect those who are of ethnic minorities, such as Blacks and Hispanics, to a greater extent than those who are Caucasian. COVID-19 is no exception. This slide shows in very stark contrast the tremendous disparities in the death rate based on race, even those who are very young and presumed healthy, as you can see on the far left side of the slide. The very far left of the slide shows the ratio of death rates, and then down below we have the different age groups from 35 to 44 all the way to 85 years and older. The dark blue color represents those who are white, the orange represents those who are Black, and the green represents those who are Hispanic or Latino. There are many different theories as to why these race groups exist when it comes to medical diseases, exist when there are medical diseases. But beyond the typical risk factors of poverty and unequal access to care, COVID-19 has disproportionately affected people who are considered critical access workers, such as those who work in grocery stores and in nursing homes. And these businesses were kept open despite the pandemic when everything else was shut down. Studies have shown that these critical access businesses tend to have a higher proportion of ethnic minorities employees, so that is likely one of the major factors for the race gaps in COVID-19. So we have finished discussing the risks for COVID-19 based on comorbidities, age, and race, and now we're going to discuss the epidemiological and clinical criteria used to diagnose COVID-19. In public health, we consult our guidelines for infectious disease in a book titled The Infectious Disease Control Manual, called IDCM, along with national agencies such as the Centers for Disease Control and Prevention, or the CDC. These guidelines determine the likelihood of someone having COVID-19 based on both the epidemiological criteria, which is the incidence or number of new cases in a population over a specified period of time, and the distribution of diseases in the general population. And we also look at the clinical criteria, which are the typical presenting symptoms of COVID-19, which we'll be discussing soon. The epidemiological criteria helps identify who is considered a close contact of someone with COVID-19 and therefore has a high likelihood of having acquired the disease. Contact tracers speak with COVID-19 positive individuals, and based on the information they provide, they identify individuals meeting the following criteria. Starting at 48 hours prior to the COVID-19 positive individual's onset of symptoms or the date of their positive test, if they're asymptomatic, individuals who are less than 6 feet for a cumulative time of at least 15 minutes in a 24-hour period. And then also, they look at individuals who have had any of the following COVID-19 positive symptoms in terms of being having physical close contact, such as hugging or kissing, sharing eating and or drinking utensils, and direct exposure to respiratory droplets, such as coughing or sneezing. So again, those things would someone be considered a close contact, even if it's less than 15 minutes. Now, I want you to know that masks are helpful, but cannot prevent 100% of the transmission of the COVID-19 virus. Everyone would have to wear an N95 mask that is perfectly fitted 100% of the time whenever they're around other people. Number one, we don't have those supplies for N95 masks. And number two, they're very uncomfortable, very hard to breathe through, so it'd be unrealistic to expect that at this point. All right, so the clinical criteria that we're going to discuss now determine the likelihood of someone having COVID-19 would include at least one of the following: cough and shortness of breath, and at least two or more of the following: fever, which would be a temperature of 100.4 or higher, chills, muscle aches, headache, sore throat, fatigue, and new change of loss of taste and or smell. Now, if you go to the urgent care or ER or hospitalized, someone could determine that you're at increased risk of having COVID-19 because of a severe respiratory illness with at least one of the following, which would be clinical or radiographic evidence of pneumonia and or acute respiratory distress syndrome, or ARDS, which is respiratory failure with rapid onset of widespread inflammation in the lung. And then lastly, and equally as important, is that there is no alternative diagnosis that is more likely than COVID-19. So here's a graph of the typical symptoms of COVID-19 in the general population in descending order, based on the percentage of individuals having each symptom. The top three symptoms, as you can see, are fever, cough, and fatigue. Based on the clinical data and the research and my own telemedicine experience of having monitored daily the most medically complex and fragile COVID-19 residents in Portage County, in my position as medical director of the county, cough is nonstop and by itself can cause shortness of breath. The fatigue, I've been told, is overwhelming, and they can barely get out of bed to go to the bathroom. I'm grateful for telemedicine because it eliminated exposure to me and my family as the medical director of the county and allowed me to fully complete my capacity there. In addition, telemedicine allows people to not have to use personal protective equipment or PPE, which was especially important early on in the pandemic when it was desperately needed by our medical heroes working in the ER, the hospital, and the ICU. In my calls to many couples, families, and multiple families living in the same household, I was really amazed at how COVID-19 presents differently in each individual. You may have one or two people who have moderate COVID-19 signs or symptoms, and then everyone else either is completely asymptomatic, they don't have any symptoms, or they have just a mild cough and a fever. It's important to note that not everyone presents with the typical symptoms of COVID-19, and one important group to mention is the geriatric population. Unlike individuals in other age groups, they can present with a fall and/or delirium, which is a change of the mental status. According to one study published in July of 2020 in the Journal of Infection by Goddard et al., titled Clinical Characteristics of Older Patients, the experience of a geriatric short-stay unit dedicated to patients with COVID-19 in France, delirium was present in more than 60% of their patients, and more than a quarter had diarrhea. So many of the symptoms of COVID-19, as you can see and maybe know from your own experience, are general and very similar to influenza, making it difficult clinically to determine if a patient has COVID-19, influenza, or possibly both. This chart helps delineate similarities and differences between the two infections. Both have a significant amount of fevers, chills, cough, and fatigue. Influenza, though, has more body aches and headache, while COVID-19 has much more shortness of breath and sometimes a loss of taste or smell. Considering COVID-19's higher infectivity, morbidity, and mortality as compared to influenza, along with the necessity to implement isolation and or quarantine, it's vital to test all individuals for COVID-19 to make a clear diagnosis, which we're going to discuss next. So before we get into the testing options, here are a couple of terms that are important to review. Sensitivity is the ability of the test to correctly identify those who truly have the disease, which would be called a true positive. Example of a false positive is a female who is given a test for prostate cancer. Remember, females don't have a prostate, and she has a positive result. That would be a false positive. Specificity is the ability of a test to correctly identify those who truly do not have a disease, which would be a true negative. Example of a false negative would be a female in her 9th month of pregnancy who's given a pregnancy test and she has a negative result. That would be a false negative. The gold standard for COVID-19 is what's called a real-time reverse transcription polymerase chain reaction, or small r, RT-PCR, commonly referred to as the PCR test. So the PCR test is able to detect several regions of the nucleocapsid protein N, which is part of the RNA gene itself of COVID-19, which is why it has such a very high sensitivity and specificity. If you remember the slide towards the beginning of the presentation, where I showed you what the COVID-19 virus looks like if it was sliced in half, and I discussed the spike proteins and pointed out the N protein, that's what the PCR test is detecting. Now, antigen tests, which are typically point-of-care evaluations, which means you get the results back in 15 to 45 minutes. On the other hand, look for molecules on the surface of the virus, which is not as sensitive or specific as the PCR. In addition, antigen tests are not able to detect COVID-19 at much lower viral loads, which can produce higher false positives and negatives. The CDC advises that if you have an antigen test result that does not seem correct, they should evaluate the epidemiological and clinical criteria to see if it is an accurate result, as we discussed. And unfortunately, it does need to be followed up with PCR testing, which is unfortunately a very good waste of resources and time, which we don't have. Antibody tests look for the presence of proteins made by the body in response to an infection called an antibody, specifically IgM and IgG. IgM antibodies are detected early on in the infection, while IgG antibodies are produced later on in the course of the infection. The problem with the antibody test is not everyone has a detectable level of IgM, and it can take up to 3 weeks to be identified. This is one of the main reasons why the CDC advises against using antibody tests to diagnose anyone with an acute or new COVID-19 infection. Now, antibody tests that test specifically for the IgG, which shows that someone has already been infected for COVID-19, is being perfected and will likely play a large role in the upcoming isolation and quarantine guidelines, along with vaccine protocols. So we talk now about isolation and quarantine. This is a large topic here, so I appreciate your patience with that. So there are 4 main ways to prevent and control COVID-19 pandemic, and they are: number 1, prevention, which is physical distancing, staying more than 6 feet apart from others, and if needed, not spending more than 15 minutes of cumulative number of time in a 24-hour period, less than 6 feet apart. It's also wearing a mask, which the CDC recently updated the recommendations about, saying that it helps prevent infection not just for other people, but for the wearer as well. And then hand washing and disinfecting surfaces are all part of prevention. That's the first main way to prevent and control COVID-19 pandemic. So number 2 is testing, which we just discussed. Number 3 is isolation and quarantine, which we're going to get into now. And number 4, the vaccine, which is coming soon. So one of the questions I was asked to address is, Why has there been such an increase in COVID-19 cases? The top reasons are some individuals don't believe in or have become lax in following the preventative measures such as physical distancing, wearing a mask, sanitizing their hands, and disinfecting surfaces. Another reason is that not everyone follows advice given by the local health department to isolate and or quarantine. And then based on contact tracing, the main events which have been super spreaders of COVID-19 is through gathering of people in their homes, such as watching football games, birthday parties, and other celebrations. Okay, so now we're going to get into some scenarios. So there are 4 scenarios put out by the CDC. And so scenario 1 is close contact with someone who's COVID-19 and will not have her further close contact. So this may be time for you to chime in here. So looking for an answer from you. So if you or this person, I had close contact on the 1st of the month with someone who is COVID-19 and will not have further contact or interactions with the person while they are sick, for example, a coworker, a neighbor, or a friend. So mind you that the quarantine period is for 24 hours later after the 1st of the month. So when would our last date of quarantine be?
The 15th.
15th.
Yeah, so it's going to be on, that's right. So we start on the 1st and we're quarantined for exactly 14 days. So if this is our last close contact with a person with COVID-19, again, this would be day 1 on the 2nd, and then we keep going forward until we get to 14 days later, which would be on the 15th or last day of quarantine of 14 days later there. All right, so close contact with someone who has COVID-19, you live with the person, but can avoid further close contact. So live with someone who has COVID-19, for example, a roommate, a partner, a family member, and that person is isolated by staying in a separate bedroom. And so you've had no close contact with that person since they isolated beginning of the 1st of the month. What's the last date of quarantine?
Still the 15th?
Yeah, exactly. I know it's hard to say the same answer again, wondering if it's a trick question, but it is. So here we have person with COVID-19 starts their home isolation, and then 14 days later on the 15th, again, last day of isolation is right there. All right, here's a 3rd scenario, excuse me, under quarantine and had additional close contact with someone who has COVID-19. So I live with someone who's had COVID-19 and started my 14-day quarantine period because we had close contact. What if I ended up having close contact with a person who is sick during my quarantine and after my quarantine started? And I'm going to give you a hint, it's going to be the same answer for both. So I'm going to ask you the second question. So what if another household member gets sick with COVID-19 during my quarantine and I have, again, close contact with them?
Yes.
Okay. So yes is an answer. All right, so here we go. So if you have an individual who is in the same household as you, and they are COVID-19 positive, their first date of your quarantine is going to start here. And then you have contact with that same person or someone else in the household that you've had contact with becomes positive for COVID-19, your quarantine is going to start over. So instead of starting on the 1st and ending on the 15th like normal, we're going to go all the way to our close contact again because it's the last day of contact and go 14 days later, now to the 19th. All right, last scenario here. So we live with someone who has COVID-19 and you cannot avoid continued close contact. So I live in a household where I cannot avoid close contact with the person who has COVID-19. I'm providing direct care to the person who's sick, don't have a separate bedroom to isolate the person who's sick or live in close quarters, or unable to keep a physical distance of 6 feet. So when would you say the quarantine time starts?
Once that person becomes asymptomatic?
Very close. So it's once that person is, and you're correct, so once that person ends their isolation period, and I say almost because we want to make sure that they're completely out of their isolation period, but you're right. So here's a person who is sick with COVID-19. You both are living in the same household. Because you're taking care of them or because you just cannot, you're having a close contact, at the end of their 10 days of the isolation period, that's when your quarantine period would start for 14 days. So great. Okay, so let's talk now about the Portage County update for you here. But before we do that, it's important for you to understand what the Ohio Public Health Advisory System is. So Public Health Advisory System is a statewide, color-coded county system based on 7 indicators that helps Ohio residents assess the degree of spread of COVID-19 within their county and surrounding regions in Ohio. And you'll see here, we'll talk about each indicator in just a minute, but here it shows you how many indicators need to be met for each level. So level 1, 2, 3, 4, we have yellow, orange, red, and purple. You'll see 0 to 1, 2 to 3, 4 to 5, and 6 to 7 would equal each indicator there. So here's a summary of the alert indicators. So I'm just going to go through them just briefly here. So there's 7 indicators. There's number 1, new cases per capita. That's used in the Ohio Public Health Advisory System. So they are number 1, new cases per capita, which is flagged when there are over 50 cases per 100,000 residents. This allows equal comparison between counties at different population sizes. And I looked this up when I was doing this presentation, and currently the lowest new cases per capita is in Carroll County, which is at 182.1. The highest is Putnam County at 1,266. We'll be looking at Portage County statistics here in just a few minutes, but they are at 284.9 right now, which is 10th from the lowest, which is the good place to be, but is way over the 50 cases. Number 2, sustained increase in new cases. And so, by the way, this indicator, along with 4, 5, and 6, are flagged when there are at least 5 consecutive days of an increasing trend of cases within the last few weeks. So number 2, sustained increase in new cases. Number 3, proportion of cases not in a congregate setting. So a congregate setting would be a nursing home, jail, prison, and those kind of things. This means community spread. Number 4, sustained increase in emergency department visits for COVID-like illness. Number 5, sustained increase in outpatient visits for COVID-like illness. Number 6, sustained increase in new COVID hospital admissions. And number 7 is intensive care unit bed occupancy. This is flagged when the percentage of ICU beds in each region goes above 80% for 3 days, and 20% of the ICU beds are being used for COVID-19 patients for at least 3 days in the last week. All right, let's go through our Portage County update here. So as you're, I'm sure, more than aware, Portage County is currently in the red. And these are our indicators that have put us in the red. So number 1 here, which is the new cases per capita, again, 284.9 per 100,000 residents. Number 2, sustained increase in new cases. Number 3, proportion of cases not in a congregate setting, which again means community spread. Number 5, sustained increase in outpatient visits for COVID-like illness. So there have never been any counties in the purple so far, which is level 4, but Franklin and Tuscarawas counties currently have what's called a high case index, which means that there are over 100 cases per 100,000 residents. This is over the last 2 weeks, which puts them at increased risk for additional indicators. Remember that number 1 was for just 50 cases per 100,000 residents. A positivity rate is the number of people who are positive when you test a certain number of individuals. So positivity rate for Ohio, as you can see, the last reporting period, November 5th, was 9.7. We're going to jump down just for a second. On November 9th, the current testing or reporting period is 12.5. You'll see the increase. The 14-day average during the last reporting period was 7.9. 14-day average currently is 10.6. Again, this is for Ohio. For Portage County, for the previous reporting period during this period of time was 8.5. The last reporting period, October 15th to 28th, is 9. Increase. And then the current reporting period up to November 4th is 10.5%. And we just did some testing, as you probably are aware, at NEOMED. And so these numbers are fresh off the press here. And they show that when we did testing on November 10th, we had 78 of 369 positive there. And that was a whopping 21.1% positive. For whatever reason, when we tested on Thursday, this is our pop-up drive-through testing at NEOMED, it was 69 of 636 cases are positive, which is still high at 10.8%. So here's the data that we pull from what's called the ODRS, or Ohio Disease Reporting System. It's reported out 3 times a week. And these are cumulative case numbers within 2 districts. One is Portage County, which does not include the city of Kent. As you may know, the city of Kent has its own health department. But this is a combined here at the top. So this is confirmed cases, 2,449 cases. Probable cases is 67. Total cases, 2,516. Number of hospitalizations, 194. Total lives lost, unfortunately, were 70. Presumed recovered, 1,678. Here are some interesting statistics regarding males versus females. So males only make up 43%, females 57%. Age range is 2 months to 100 years. The median age is 32, which is really interesting because when we first started keeping data back in March, April, the median age was in the 60s. So that means we've had a huge number of young patients, residents who have gotten COVID-19, and that's brought that median age down now to 32. It's actually starting to increase a little bit now. This is the race distribution. So whites 76, blacks 5%, Asians 1%, Hispanic 2%, other 3%, unknown 13%. And this is just based on data that were given by the state. So the total number of the 7-day case average is 56 cases per day, and that's broken down into the city of Kent, which is 13. And for the rest of the county, excluding Kent, which is Portage County Health Department's jurisdiction, is 43 cases, and this is per day. This is what we share with the schools. Have a weekly meeting with all the superintendents in Portage County, and we share with them our school-associated positive COVID-19 cases. You'll see the different date ranges here every single week. This is the number of cases that are positive in the schools that they report to us, so 11, 22, 19, 6, and then back up to 10. This is in the schools, again, total under 18 positive cases, 113. Total of under 18 who are currently being monitored, 227. And then this total under 18 contacts converted to positive cases, 25. So it's only been in the last 3 to 4 weeks or so that we've actually had a number of individuals in our schools, of course under 18, who have now converted to positive cases. So this is quite significant. And then this bottom graph just shows total confirmed positive cases under 18 years of age. This is for the whole county. So you see we had one way back September 18th to the 24th, and now we're up to 17. This is confirmed COVID-19 cases in Portage County by zip code. So you'll see over here, so the really dark color, the blue, and the dark red-orange are the highest numbers. So on the western part of the county are where we have our highest number, including Ravenna, our seat for Portage County. This is Kent State University, and again, the city of Kent is within the different jurisdiction, but this shows you everything here in terms of percentage of positive cases by zip code. This is COVID-19 confirmed positive cases reported to Portage County Health District. The blue is cases reported per day, and the red is a 7-day average. So you'll see starting on May 1st, how we have bumped along, and now of course we're having a spike. Same thing for both of these. This is confirmed COVID-19 cases per day in Portage County by date of illness onset, and it should be up until November 13th, 2020. So the green is the symptomatic, the blue is asymptomatic. So these are cases reported to us by date of illness onset. So starting from March 6th all the way to November 1st, or November 13th. Again, symptomatic and asymptomatic, you'll see that we had a spike in the beginning and then in the summer. And now, as you well know, we're having a big spike now. So what's the status of the hospital systems in our area? The hospitals in our region are approaching 75 to 90% capacity for their inpatient beds for all patients, not just COVID-19 patients. We were told on last week's Akron Regional Hospital Association call that the strain on their healthcare personnel right now is similar to the peak of influenza season, which has not even started. This is due to the number of staff that are isolated or quarantined due to COVID-19. And they took a little kind of electronic clipping, in a sense, about the Cleveland Clinic. So they extended their postponement of non-essential surgeries that require hospital stays through November 20th. And of course, that's due to the current COVID-19 pandemic. Thank you so much for allowing me this opportunity to talk to you all about COVID-19. I'm now open to questions that you may have about this or anything else.
So you can either unmute and ask your question yourself, or you can type it in the chat and we'll share it with the group.
Okay.
I have a question just about what type of test is being done with the mass testing, like what's being done at NEOMED?
Great question. So we are doing what's called anterior nasal, which means just in the tip of the nose, swabs that are sent off to a high complexity lab, meaning it's doing that PCR testing. and we're getting the results back in no less than 48 hours. And we are going to have additional testing. That is the dates and the times and locations and those kind of things are on our website, the Portage County Combined General Health District. And those will be walk-in clinics because of the cold and those kind of things, and because of the locations. And those will be exact same in terms of anterior nasal testing with PCR.
I have a question about face mask requirements. I know the governor had mentioned that everybody in going into any business should have a face mask on. I have to tell you, I was in Portage County this morning getting gas, and 3 people walked in to, I guess I can say, into the Get and Go without masks. Is that something, is anybody monitoring that, or is that something that is reportable? I just don't know what the, you know, I just waited till they came back out before I went in to pay, because I'm like, sorry, don't want to expose myself to knuckleheads, sorry.
Thank you for your question. So I'm the medical director and not the director of the environmental control department at Portage County. So I'm going to defer that to them and to our health commissioner. But I will say, when I watched Governor DeWine's address, was it this last Thursday, he mentioned that they're going to increase the number of individuals that are in their compliance unit to make sure that restaurants and businesses and everyone is following the increased mask order, in terms of businesses having a sign stating that they need to wear a mask, and that there can be first a written warning, and then also after that they can shut the business down for 24 hours. The best answer I can give you is to call the health department for whatever location that was and notify them of that, and they will follow up.
We have a question from Kent Westerfield about whether someone can get COVID-19 more than once.
Great, thank you for that question. So thankfully, that is very, very rare in order for someone to get COVID-19 again. There have been a few reported cases that you may have seen in the news, but at this point, the CDC is standing by that almost without exception, that once you've had COVID-19, that you will not get it again for 3 months or 90 days. There were some additional studies that were done that showed that people had antibodies in their system up to about 7 months. And this is specifically, by the way, for that N protein and those spike proteins that we talked about. But at this point, the CDC is only standing behind 3 months. So that's kind of our best case scenario. And we'll certainly see with the vaccine in terms of how long that immunity lasts. It's very encouraging regarding the 90% effective rate that is currently out there with the vaccine. And we're hoping that we'll get a lot more data to make that determination of how long that, that lasts.
So I have a question. Thank you for the talk, Dr. Arredondo. So if somebody is, they're going to be traveling for Thanksgiving, and so they say, hey, I want to get a test before I leave to make sure I'm not going to infect my family, and they're asymptomatic with no known exposure, and they have one of these rapid point of care tests and it's positive. Would you say that there's a likelihood that could be a false positive and they should go and get a PCR test, or should they just cancel their trip?
So it would be my recommendation for people not to travel, but I understand that everyone makes their own decision about such things. And direct answer to your question, and thanks, John, is if their point of care testing that we discussed that does not have as high of a sensitivity and specificity is positive, I would encourage people to get a PCR follow-up test. Now, what we look at is, as in terms of your scenario, were they around anyone that they knew had COVID-19? They don't. But you also have to remember that 50% of the spread of COVID-19 is through people who are asymptomatic, who don't have any symptoms. So it may not be obvious to us that they have COVID, but the spread is mainly through asymptomatic spread. So in answer to your question, I would get a PCR test if you're headed that way. In regards to your thinking, and the sooner the better, because it can take a lab depending which lab you're talking about, 2, 3, 4, 5 days to get the results back, which are not that useful. And then number 2, if you are positive, you want to be able to give the local health department time to contact you, so they can't start the contact tracing until that information is put into that Ohio Department reporting system, ODRS system, so they know that you're positive for sure. And then they need to contact you and let you know. So it would be better to get that as soon as possible if that's your plan.
Thank you.
I have a question.
Yes.
Could you just explain again, like the relationship of how like a person with hypertension is at like a more increased risk than others?
Sure. So I'm not going to try to get up my slide right now, but if you remember from that slide, one of the ways that COVID-19 has been shown to enter the cell is through the angiotensin converting enzyme 2, which is a receptor that is used for blood pressure. And so it's been interesting that for some reason, we don't understand it completely, but those who have high blood pressure or hypertension or other associated conditions such as diabetes, kidney disease, heart electrical problems, heart failure, all associated with the blood pressure, vessel control, are at increased risk of COVID-19 in terms of severity of symptoms, and typically can result in hospitalization and those things. Does that answer your question?
We have a question, Dr. Ballister. Any use of colchicine as an anti-inflammatory, and how long should patients receive steroids?
So in terms of steroids, that's been about the only class of medication that has been shown to be effective through studies, whether it be dexamethasone or other things. In terms of other medications, whether it be risaltamavir or other ones, really the jury's a little bit out. We've had some conflicting studies that, whether it's the World Health Organization or other ones, that have supported other medications or not. But basically those medications are really used in the hospital and typically the ICU setting. And I wouldn't want to go into terms of doses and those kind of things. I'd have to go look at the medications themselves to determine that.
Okay. Any suggestions for treatment of brain fog?
I'm not sure what that's referring to in terms of COVID-19 causing some confusion and things, or what does that mean? What is that questioning?
That would be my guess, is the sort of reported.
Unfortunately, there's not a whole lot of things that we can do to help ourselves during COVID-19, other than typical things like Tylenol, which would be acetaminophen, NSAIDs, non-steroidal anti-inflammatory drugs, specifically like ibuprofen and things. Early on, there's a question about whether they were going to cause any severe side effects and problems, but that has been proven to be okay. So taking Tylenol, ibuprofen, over-the-counter types of medications, plenty of fluids, and rest are the best things to help with that. And anything that one can do to improve your general health in terms of diet, exercise, stress reduction, and those things would be most helpful. But unfortunately, there's not been anything that's really been proven to reverse at this point, per se, COVID-19. There are some small studies about some intranasal type medications and things, but those are very small and are still under investigation.
Great. A question about vitamin C and zinc. Do you know of any benefit?
No, other than possibly some benefit of helping your general health. There's nothing, unfortunately, that we could do to help prevent from contracting COVID-19, other than preventative measures that have been proven, as you can remember or know, that this is a respiratory virus. So staying those less than 6 feet for less than 15 minutes in a 24-hour period, wearing a mask, washing your hands, disinfecting surfaces are really the main things. And in terms of washing hands and disinfecting surfaces, COVID-19 has been shown to be present on surfaces depending on the type of material for up to about 5 days. Now remember, though, that it's mostly transmitted through respiratory virus droplets, and there is concern for what's called aerosolization, which means that the COVID-19 can be on the humidity, in a sense, the water in the air, and can travel more than 6 feet. So again, doing the best that we can. It's wearing that mask, washing hands, staying less than 6 feet apart, and disinfecting. Other things are just really about general health, and there's nothing that we can do, unfortunately, at this point, to prevent that until the vaccine does come out.
Okay, and then one final one. Could you talk about some of the long-term effects of COVID?
Yeah, this is something that is becoming a real issue, and there's been a variety of signs and symptoms for those who have COVID-19, whether it be an extended amount of fatigue. Fatigue is a very big part of COVID-19 during the illness, and people can experience that for weeks or even months afterwards. And you mentioned about the kind of brain fog and things like that. Unfortunately, we're finding out that a lot of people can have some mental status issues weeks or months, and that depends as well if they were intubated, if they're in ICU, in the hospital, and those things can be additional factors. But more and more, we're finding some neurologic issues involved with COVID-19, and the press is out on that. We'll be learning about that more as the virus is out there longer. As we all know, this is a new virus as of December 31st of 2019, and so we're still learning about it.
Alrighty, thank you very much. We're going to go ahead and wrap up here. Thank you all for joining us.